You know that feeling when your heart suddenly just takes off, racing for no apparent reason? It can be pretty scary, right? Well, one of the most common culprits behind that is something called supraventricular tachycardia, or SVT for short. And that's what we're diving into today. We're going to break down exactly what's going on inside your heart when one of these episodes hits. So picture this. You're just sitting there, totally calm, and bam, your heart rate just skyrockets to 180 beats per minute. I mean, that's often more than double a normal resting heart rate. And this isn't like when you're working out where it kind of builds up. Nope, this is like a light switch just flips on and your heart is suddenly off to the races. That's suddenness. That's a huge part of what makes SVT feel the way it does.
All right, to really get a handle on SVT, I think the best place to start is with the person who's actually going through it. So let's put ourselves in their shoes. What does this actually feel like when it's happening? Okay, so when an SVT episode kicks in, the number one thing people talk about is palpitations. And they often say it feels like a really fast, hard pounding in their neck. But it's not just that. You can also get hit with a bunch of other stuff: dizziness, feeling short of breath, and this really intense feeling of anxiety. Now, it's worth pointing out that actually passing out from this is pretty rare, but feeling like you're about to, yeah, that's super common. And here's a really, really big clue for doctors: how the whole thing starts and stops. You see, SVT is what we call paroxysmal. That's just a fancy way of saying it starts out of nowhere and then stops just as suddenly. It's a key difference from, say, sinus tachycardia, the normal fast heart rate you get from exercise or stress. That kind of tachycardia ramps up and then it ramps back down. SVT is more like an on-off switch. So, a patient walks in, tells you this story. How do you know for sure it's SVT? Well, this is where the medical detective work kicks in. And it all starts with one absolutely essential tool: the electrocardiogram, or as we all know it, the ECG. Now, before we can spot the problem, we've got to know what normal looks like, right? So here it is. This is a standard ECG of a healthy heart in what's called sinus rhythm. See how the peaks are all regular, nicely spaced out? The heart rate is nice and calm. This is our baseline. Remember what this looks like. And, well, take a look at this. This is an ECG taken during an SVT episode. The difference is just dramatic. The rhythm is still perfectly regular, but look how fast it is. The peaks, what we call the QRS complexes, are all crammed right up against each other. It's night and day. Okay, so when a doctor or nurse sees an ECG that looks like that, the very first question that pops into their head is this: is the QRS complex narrow or wide? That one question is the fork in the road. It's the start of the whole diagnostic pathway. And the answer tells us a ton about where in the heart this electrical problem is coming from. So here's the deal. A narrow QRS complex, and we're talking less than 120 milliseconds wide, tells us that the electrical signal is starting above the main pumping chambers, the ventricles. And that's exactly where the name comes from. Supra means above, so supraventricular tachycardia. The problem is happening above the ventricles. A wide complex? That's a different story. It's a bit more worrisome because it might be the more dangerous cousin, ventricular tachycardia. Right, so SVT is actually kind of an umbrella term. It's not just one single thing. It's more like a family of related arrhythmias. The most common one by a long shot is called AVN-RT. That's caused by a little short circuit right inside the AV node itself. Then you've got AVRT, which uses an extra wire and accessory pathway. And finally, there's atrial tachycardia, which comes from just one irritable spot in the atria that starts firing off way too fast. So, the big question is, how does this actually happen? What's going on electrically? Well, for the most common types of SVT, the mechanism is something called re-entry. And honestly, the best way to think about re-entry is to just picture a short circuit in the heart's electrical system. That's really all it is. And the whole stage for this electrical drama is set right here in what's called the AV node. Think of the AV node as the main electrical gateway between the top chambers of the heart and the bottom ones. Now, in a lot of people, this gateway isn't just a single road. It actually has two lanes, a fast pathway and a slow pathway. Most of the time, this is no big deal, but it's what creates the potential for that short circuit to happen. Okay, let's walk through exactly how this short circuit gets going. It all starts with one single premature beat coming from the atria. This early beat gets down to the AV node and it tries to go down the fast pathway, but oops, the road is closed. It's refractory or busy. So the signal has no choice but to take the scenic route down the slow pathway. Now, because it's slow, by the time that signal reaches the bottom, guess what? the fast pathway has reopened. So the signal sees this open highway going back up, and it zips right back up to the top. And just like that, you've created a loop. That signal just goes round and round and round, and that rapid loop is the engine driving the SVT.
Now, the other big type of reentry SVT, AVRT, works on a similar idea. But instead of two pathways inside the node, this one happens because there's a whole separate extra electrical wire connecting the atria and the ventricles. We call it an accessory pathway. So if the signal goes down the normal AV node and then comes back up this extra wire, you get a narrow complex SVT. But if it goes the other way, down the extra wire first and then up the normal way, it creates a wide complex tachycardia. And that can look almost identical to the much more dangerous ventricular tachycardia, which is a real diagnostic challenge. Okay, so we know what it is and how it happens. Now for the really important part. How do we shut it down? The game plan here depends entirely on one thing. Is the patient stable or unstable? Let's take a look at how we get that heart back into a normal rhythm. All right, first things first, and this is non-negotiable. If a patient with SVT is unstable, and by that I mean their blood pressure is tanking, they're confused, or they're showing signs of shock, we don't mess around. The treatment is immediate electrical cardioversion. It's a controlled shock timed perfectly with a heartbeat that basically acts as a hard reset for the whole electrical system. There is absolutely no time to waste in this situation. Thankfully, the vast majority of patients are stable. And for them, we always start with the simplest things first. We try what are called vagal maneuvers. These are just physical things, like asking the patient to bear down like they're trying to have a bowel movement. What that does is it stimulates the vagus nerve, and that nerve is like the brake pedal for the AV node. By slamming on the brakes, we can often slow things down just enough to break that short circuit and stop the SVT cold. Okay, so let's say the vagal maneuvers don't cut it. Then we move on to medications. And the go-to first-line drug is adenosine. This stuff is pretty amazing. You give it as a super fast IV push, and for just a few seconds, it completely blocks the AV node. It's like hitting Control-Alt-Delete on the heart's electrical system, a chemical cardioversion. If that doesn't work, we can try a second dose or move on to other drugs like beta blockers or calcium channel blockers. They also slow down the AV node, just not quite as dramatically as adenosine. Now, for people who keep having these episodes and it's really affecting their life, we actually have a cure. It's a procedure called a catheter ablation. A heart rhythm specialist and electrophysiologist carefully threads a catheter up into the heart. They find that problematic slow pathway or that extra accessory wire, and they use a tiny bit of energy to basically destroy it. By getting rid of one of the roads in that short circuit, you permanently fix the problem. All right, let's just quickly pull all that together. What are the key takeaways? First, the patient story is everything. That sudden on, sudden off racing heart is the classic clue. Second, we crack the code with an ECG, looking for that fast, regular, narrow complex rhythm. Third, remember the cause. It's almost always a short circuit, a re-entry loop. And finally, the fix. We target the AV node. We start with vagal maneuvers, then move to adenosine, and for a permanent cure, there's catheter ablation. And that brings me to one last thing to think about. You know, these smartwatches we all wear are getting insanely good at taking ECGs, so it really makes you wonder, right? In the very near future, who's going to be the first one to spot an SVT? Is it going to be the doctor in a clinic, or is it going to be the patient just looking down at their wrist? Kind of changes things, doesn't it?